Welcome to AZENT's Guideline Updates, Episode G5, COPD Exacerbations. I am Dr. Z. KC is here with me. Educational only, not individual medical advice.
So before we get into the guidelines, I want to share something that happened on my last COPD admission. Patient came in, got 14 days of prednisone, went home without any new inhalers. Back in 6 weeks.
That story is exactly what Gold 2025 is trying to fix. And I want to say, both parts of it, the oversteroid and the under-optimized discharge.
Let us start with what is new in Gold 2025.
The biggest structural addition is the Rome proposal classification, now embedded in Gold 2025. It gives you a bedside severity framework based on physiology, not on where you admit the patient.
Before this, severity was just floor versus step-down versus ICU?
Basically, the Rome classification tells you the physiological severity at the point of care and drives your treatment decisions in real time. Level 1. No acidosis. Oxygen saturation 88% or above. These patients can usually be managed on the general floor with standard treatment. Level 2. Some acidosis. pH between 7.25 and 7.35 or saturation below 88%. Step down or intermediate care, consider NIV. Level 3. Severe acidosis, pH below 7.25 or respiratory failure. ICU and intubation or NIV are likely in the picture.
So if I am in the ED with a COPD patient and I get an ABG that shows pH 7.30, that is automatically a level 2 and probably needs closer monitoring.
Exactly. You document that classification and use it to justify your level of care decision. It also gives you a framework for escalation triggers. If the patient starts at level 1, but the pH drops below 7.35, they have moved to level 2.
Let us talk about acute management. I feel like a lot of this is the same, but done wrong.
Right? The core elements are stable. Short-acting bronchodilators, which means albuterol and ipratropium combined. Oxygen targeting saturation 88 to 92%, not higher. Steroids, prednisone 40 milligrams daily for 5 days. That is it. Not 10 to 14 days.
Where did the 14-day course come from? I see it ordered constantly.
Old habit. The evidence has supported 5-day courses for years, and Gold has reflected that. A 5-day course of prednisone 40 milligrams is as effective as a longer course and causes less hyperglycemia, less adrenal suppression, and less skin issues. The guideline is unambiguous on this.
What about oxygen? I feel like every COPD patient gets a nasal cannula on 2 liters, and nobody thinks about it.
The target is 88 to 92%, not 98. High-flow oxygen in a CO2 retainer suppresses the hypoxic drive and can worsen hypercapnia. Use a Venturi mask if you need precise VO2 delivery. Get an ABG 30 to 60 minutes after initiating oxygen to confirm you are not worsening the respiratory acidosis.
An NIV?
BiPAP for pH below 7.35 with increased work of breathing. This is one of the most evidence-supported interventions in all of hospital medicine for COPD. It reduces intubation rates, length of stay, and mortality in appropriate candidates. Do not wait until the pH hits 7.20 before you initiate it.
What triggers antibiotics in COPD exacerbation?
Cardinal symptoms: increased dyspnea, increased sputum volume, and purulent sputum. If the patient has at least one cardinal symptom and purulent sputum is one of them, antibiotics are indicated. If they have increased dyspnea and more sputum, but the sputum is clear, antibiotics may not be required. 5 days maximum duration. Procalcitonin can help support the decision, though it is less reliable in COPD than in CAP.
Okay, now the part 1 thing gets really neglected. Discharge.
This is where the chronic disease management lives. The discharge from a COPD exacerbation should not just be about stabilizing the acute episode. You need to optimize maintenance therapy before the patient leaves. That means starting LAMA or LABA plus LAMA if they're not on it. Do not discharge without initiating or optimizing long-acting bronchodilators.
What about ICS, the inhaled corticosteroids?
Gold 2025 has updated guidance on ICS withdrawal. If a patient is already on triple therapy, which is LABA plus LAMA plus ICS, do not withdraw ICS unless it was started inappropriately or is causing significant adverse effects, especially if the eosinophil count is above 300. Withdrawing ICS in that group increases exacerbation risk.
Check eosinophils. Is that the driver for the biologic too?
Yes. Dupilumab is now added to the GOLD 2025 algorithm for patients on triple therapy with ongoing exacerbations, eosinophils at or above 300, and chronic bronchitis symptoms. This is a new biologic indication. Ensure proper patient selection. They need to be on triple therapy already and still exacerbating. It is not a first-line add-on.
And ensifentrine?
New mechanism drug, PDE3 and PDE4 inhibitor combined. Added as an add-on to dual bronchodilator therapy for persistent dyspnea in patients not at goal on LABA plus LAMA. It may not be on every formulary yet, so check availability, but represents the first novel COPD mechanism in years.
At discharge, what else?
Vaccinations, pneumococcal and influenza. Pulmonary rehab referral within 4 weeks. Follow-up within 2 weeks. Azithromycin prophylaxis for recurrent exacerbators without cardiovascular contraindications and without active smoking status. Check the QTC first.
3 things I am doing differently after every COPD admission from now on.
Tell me.
1. 5 days of prednisone, not 14. 2. Check eosinophils to guide ICS decision and eventual biologic eligibility. 3. No discharge without a long-acting bronchodilator in the regimen and a follow-up plan.
That is the episode. COPD, exacerbation done. Up next is G6, acute kidney injury. KDIGO 2012 is still the guideline, but there is a major update in draft review, and we need to know how to practice in that gap. This is AZENS.